right, so for our last panel, really looking forward to it. As I jokingly said, Ryan had the toughest job. That was the opportunity to share great information, Tucker's energy. This group's the one who's going to give you all the answers. No pressure, guys. But good afternoon, everybody, and thank you for joining us for this important conversation. We're at a moment where California's healthcare system is under real pressure. Medi-Cal cuts are looming, the state budget picture is uncertain, and several high-impact ballot initiatives are set to shape the policy landscape for years to come. It's in times like these that it's critical that we come together across sectors to understand what's at stake, to think creatively, thank you, Tucker, for some of that, and how we can protect access to care for millions of Californians who rely on our organizations every day. This panel, which I'm pleased to moderate, brings together leaders who sit at the center of these issues, who bring deep and candid insights into what lies ahead. And I'm honored to be joined by Dustin Corcoran. Dustin is the CEO with the California Medical Association. Next to Dustin, we have Kathryn Scott. Kat is the Senior Vice President of State Relations and Advocacy for the California Hospital Association. And on our far side, Francisco Silva. Francisco is the President and CEO of the California Primary Care Association. So together they represent physicians, hospitals, and primary care providers, three pillars of our healthcare delivery system. These perspectives will help us not only with the challenges, but also the opportunities for alignment and advocacy as we move towards an unpredictable legislative and budget session. So with that, let's dive in. And I'm gonna start with the easy sort of softball question. You know, we're a little soft down here in San Diego. We've had some rain for a couple days and everybody's freaked out about the weather, right? It's cold outside, so we went indoors. Cold was 61 degrees, let's just level set. So with that, if you had, and I'll start with you, Dustin, if you had to describe California's health policy climate right now using a weather forecast, what would that be?
Frigid.
Frigid, there we go. Kat?
Cloudy with a chance of tornadoes.
Chilly with thunder. And a storm on the horizon.
Storm is on the horizon. I think that's fair to say. So with that, just want to get the group warmed up. Obviously, keep the energy in this room. So before we get in the back and forth, I do want to give each of you a chance to set the stage from your perspective. Obviously, there's a big year ahead. We will have a new governor in the future, shifting political dynamics. Prop 50 obviously is going to change, throw some curveballs into our congressional seats, as well as there's ongoing pressure on Medi-Cal and the budget. So I'd like to hear from each of you, what's rising to the top for each of your organizations? So as you look to 2026, what's the focus of your priorities for your respective organizations and what's driving those decisions? So Dustin, if I can start with you.
Yeah, I think the name of the game right now is uncertainty and helping our members wherever they sit in the continuum care, whether they're a solo practitioner or in a large integrated system, really weather the storm. And I think back, since we just listened to poetry, I think back to one of those great philosophizer poets, Don Rumsfeld, who said at a press conference in response to a reporter, there are things there are things that we know, there are things that we know that we don't know, and there are things that we don't know. And I think that pretty well sums up where we're at right now. And I think what's rising to the top, and I actually leave from here to get on a train to go up to Santa Barbara for our CMA Executive Committee retreat. And what we're really going to be running to ground there is how we help provide a ballast to providers in these times of uncertainty, that hopefully we can provide some certainty for them for those things that they don't know or they don't know that they don't know. And that's going to come in a lot of different ways. Obviously, the Medicaid cuts are looming large. The provider tax uncertainty is looming large. The Medicare uncertainty for physician payments is looming large. The vast number of increase in uninsured individuals is looming large. We still have continued consolidation. We still have continued entrance of private equity into the physician market space. There's a lot of things that are creating that uncertainty, and I think it's imperative on the associations, all of ours that are up here, to provide that ballast and to try and provide pathways out of that. And I do appreciate, Dimitri, that you had the speaker that you had right before us, because I think the big takeaway from him that I hope you all took is it's really easy right now to just get super depressed and super sad and have a reaction of just putting our head in the sand and calling it quits or doing something else, or just assuming that the best days of healthcare are behind us. Or we can challenge ourselves, and that's our challenge this weekend at our executive committee retreat, to find the pathways out, to find the creativity, to find the opportunities that lie in this moment to build for a better future. And I think we can. I think we can flip this moment on its head and to take what's really awful and really terrible right now and to find pathways out and to build better. And we look back on it in 10 years and said, we actually used that as a launching point as opposed to a point of depression.
Yeah.
Yeah? All right. I'll take that, Kat. Thank you.
What he said, yeah. I don't know, Francisco, if you...
Am I going next?
Yeah.
We're not going in order.
No.
I would say, for the health centers, and I think it's helpful to just provide some context, just not to assume that everybody knows the footprint of the health centers across the state. We're about the 2,400 sites across the state, about 190 different FQs, serving about 7.2 million unique patients, over 31 million encounters. 1 in 4 patients on Medi-Cal get care at a health center. Half of the primary care visits in Medi-Cal happen in a health center. I say that all to say that we're very dependent on Medicaid. And that's about 70% of our revenue. We're a lot more diverse than that. Medicare is like 15% in some communities. But what's keeping us up at night right now is when you have the cascading impact of HR1 cuts, the elimination of coverage for undocumented immigrants, ICE in the streets that may force people not to get care. When you put that all on top of each other and these ballot initiatives that are existential to our model of care, the main concern is how do we deal in an environment where we have more people that are not uninsured without coverage, when you put them all together. The state, we had gone from about 16% uninsured down to about 4%. It was a huge accomplishment. And we're all tied together, right? The clinics, like the hospitals, we have to see everyone regardless. So what's keeping us up at night in this new environment, and I'll take you up on that challenge, Dustin, and this is what we're talking about. If we're shifting back to that model where we have more people that are still our patients, we're still gonna see them, how are we gonna do it if they don't have traditional coverage? Does it look different way? And our challenge now is how do we deal with these? I know we're gonna talk about it a little more, some of these immediate challenges in this moment in time, and not lose sight of the future, right? Not lose sight of the things that we wanted to do. The model for health centers is we wanted to be there for everyone, regardless of insurance. That's the overarching goal, and provide care to folks with dignity. But how do we still do that in the future, in this moment, in this crisis?
Yeah, and having had our board meeting a month or two ago now, as we started to look out and see where we were going to be for the next year, we also looked at where we're going to be, to your point, Francisco, where we're going to be in the next 5 years, starting Project 2020X, as we call it, which is really looking out 5 years, looking out 6 years, and trying to understand where we're going to go. And frankly, I think what's going to be important is really listening to our providers. They announced a new commission today, and it was filled with providers, and we got some pushback that the associations weren't on it. Why aren't the associations on it? Because I don't provide service. I represent you doing and providing service, and I look forward to your weekend, with providers as we do the work we need to do in Sacramento. It's going to be critical that we do it representing what you all do and how you all do it. And as we face the financial challenges, I call it the chessboard at CHA, because our priorities this year are protecting, preserving, and promoting as much money as we can. I'm just going to, money, reimbursement, however we want to call it, we have to pay for the service at the end of the day. And then moving forward to the other chessboard piece, the initiatives, we'll talk about in a little while. Managing that political piece is going to be important, that it doesn't become distracting to the first piece, right? As frustrated as we all are, it cannot be a distraction to ensuring we preserve the very care and service you all provide, whether that's an increase in uncompensated care, which our hospitals will do, period, full stop. Our uncompensated care will go up. And then the last, of course, is how do we subtract, which is why I absolutely, Dimitrios, love the previous speaker, is how do we do that with the Office of Healthcare Affordability over our heads, trying to find that balance when we're looking and staring down 3.5%. We're hoping the lawsuit helps us with that. But at the end of the day, there's going to be a cap on what we can bring in. And so how we manage that's going to require some subtraction from our perspective.
And Kat, I think that's interesting. You talk about what we would refer to as a lot of headwinds that are out there. Some of it's caused by our legislature, some is caused by actions they take, Office of Healthcare Affordability. And then there's others, which is the initiative process. So why don't we go there? I know, Kat, you referenced that, which is another sort of can of worms that we've seen used appropriately for things that are to the positive, and then at other times used as a tool in a negative sense. So we know there are a number of initiatives that have been filed. Some have already started the signature gathering process. Others, we're expecting some others. So Francisco, I'll start with you at the far end, and Kat, go to you next. Which upcoming initiatives could most reshape the healthcare landscape for better or worse?
I'm just going to go ahead and call them what they are, right? We know there's two initiatives. One's targeting the hospitals and the medical groups. One that's targeting the health centers, and they're shakedowns. That's plain and simple what they are. We've seen that playbook over the last 12 years, where it's a ballot initiative that's really not meant to solve anything. It's not a debate about executive compensation. It's not a debate about how health centers spend their dollars. That's not really what it's about. So for health centers, the ballot initiative that SEIU UHW filed, for those of you that might not have heard about it, essentially would siphon off about $1.7 billion from health centers. This is on top of our expected cut with the HR 1 cuts is anywhere between $5 to $6 billion. The loss in coverage for undocumented immigrants is about $1 billion, and then $1.7 billion on top of this. We will end up losing clinics across the state. The independent research that we did, we expect about 47% of the clinics would have to close because they'd be operating at negative 11 margin or less. And it's done through our 990s, a target in our 990s. So, I think what I would say on that one, and then there's the ballot initiative targeting the hospitals also, that's top of mind. And we're connected. The healthcare system's connected. And if we fall, that impacts the providers, that impacts the hospitals. If the hospitals fall, it's the same thing. So I think those are existential for healthcare. It's also an opportunity for us to come together. And that's why at the beginning I called it, that's what it is. And I think it's time for us to be able to say, it's not about patients. It's not about healthcare. This is a shakedown. And it's not appropriate at a time that healthcare is in jeopardy in California.
Yeah, agree. Obviously, top of mind for me is the compensation cap initiative that was filed, as Francisco mentioned, because it would, from our perspective, it's not just that CEO, right? It's the C-suite, the IT guy. I tell legislators all the time, I'm always worried about the leadership of a hospital, but I will not give my medical record to somebody who's paying $350,000 to the cybersecurity person. Because could you imagine the top of cybersecurity for your system can't compete with IT? How do we protect that medical record, right? So it's the depth of that expertise that the compensation cap will jeopardize within your own organizations, and the competitiveness we will lose out to, not just in the healthcare space, but in that technology space as well. So deeply worried about that, equally worried about what the clinic measure will do to our services in that primary care space, in the specialty care place, where we know our ERs are overcrowded already. I'll flip the narrative really quick. The one we think is going to be the best initiative on the ballot is the union transparency measure. We will have title and summary. It will be difficult. We won't love it. But we have a great firm who will help us move that initiative. And again, this is the initiative that requires full disclosure of political spend for healthcare unions, and then will require a vote of about a third of the union's members to ensure before they spend over $100,000 or $1 million on a statewide ballot. And just so you all can put that in reference, we think most unions get about 5 to 8% total vote for leadership. This would require it to go up 20,000, 30,000 more votes. So we think it'll be very difficult for them to be able to do the kind of shakedown that Francisco's referencing, because it'll be hard to get the vote to do a statewide ballot measure, to spend the money to get it qualified, to spend the money to move it forward. So we'll start to curtail those actions. So flipping it a little, I'll give you my best.
Yeah, no. Those are both interesting. Obviously, you can see sort of both sides of the coin, as Kat said there. A couple of examples of ones that are problematic, and one, obviously, that we're supportive of. Dustin, obviously, you've been around. You've seen a lot of these initiatives. You've been involved, whether it's Prop 35 and other initiatives, but any thoughts you have on the process there?
Yeah, I've chaired 3 different ballot measures in California and negotiated a 4th one off the ballot, both on the yes and no side. I think both the UHW ballot measures are imminently beatable and are likely to go down or not to get on the ballot at the end of the day. And I think there's a mutually assured destruction, candidly, with the proactive one that CHA is doing as well. One of the things that I think most people underestimate is how smart voters actually are. And voters usually do a pretty good job, actually, of peering through the motivation of a ballot measure and seeing kind of what the undercarriage of it is. When we did Prop 46, that was a no campaign. That was a trial lawyer attack on MICRA and our medical protections on Medi-Cal. But they ran it as a drug and alcohol testing safety measure that physicians should have to be subjected to the same things that athletes are and everything else. It was a very cynical campaign. It wasn't really what the initiative was about. The initiative was really about getting rid of the Medi-Cal caps. And voters could see through that. It wasn't a particularly hard campaign to run. I was happy to take all the credit for it, of course, but we won by more than 2/3. We won every single county in California because voters can get to that cynicism, I think, very quickly, generally. I mean, that doesn't mean that you two don't have to execute on a campaign. You still have to run it. You have to finance it. You have to do all of those things. You have to execute well. But voters tend to get to a cynical place pretty quick if they see. It's harder to run a yes campaign than it is a no campaign, just fundamentally in California. I'd like to bring up a ballot measure that is not on the current list that I think should be top of mind, and it's an opportunity as opposed to a negative. And these 3 ballot measures really represent kind of trying to create the best outcome of this is like Stacey's, right? It's like that everything will just be the same after tens of millions of dollars are spent. There's an opportunistic one, and that's Prop 55, which was run at the same time our tobacco tax at Prop 56 was run. Prop 55 has to come up for renewal. Prop 55 was the high-income earner tax in California, and it dedicated a lot of revenue to education. It dedicated revenue to the general fund. In theory, it was supposed to generate revenue for healthcare as well. But the way that the final ballot measure was written is in that waterfall. By the time it got to healthcare, there was no water left. It was like education and the general fund were up in the Niagara Falls part of that waterfall, and healthcare was in the Sahara Desert. So it was not a great deal for healthcare. That's going to have to come back up for renewal either in 2026 or 2028. CHA was a major financier of it back in 2016, even though we were down out in the Sahara Desert. There's a real opportunity with what's going on in healthcare right now to have a different conversation, a different dialogue with CTA, with SEIU, and some of the other major proponents of that because of its significant implications if that were to not be renewed for education, for the general fund, and carving out a legitimate and real space for healthcare in this moment. So, we have ones that are cynical by nature. We have ones that are, really just, as Francisco said, I think it laid it out pretty plainly. But let's also look at the creativity opportunities of something that maybe we can carve a path for healthcare and to generate new revenue, or potentially to put fixes in for things like coming into compliance on provider taxes if we need to do that. So keep that in mind, that there's not just negatives, there's also opportunities through the ballot.
Absolutely, and that is a great reminder. So something to keep our eye on in the coming years. So thank you for that. Kat, I'll start with you on the next question. So we're heading into a major election cycle. Once we're through this, we will end up with a new governor coming in, as well as Proposition 50 shaking up at least several congressional races here in California. How do these political shifts change the way our sectors need to advocate together?
It's a really good question because the hard part is I'm now in my third decade of doing this, and this will be my fourth or fifth. I don't know. We were doing this together. Fourth or fifth governor, right? I think Prop 35 allowed us all to really work together in a way we haven't in a little while. We've always worked together, tobacco taxes, et cetera. But I think it sort of reunited us to a place where we have more conversation together. We strategize together. So I really don't see a whole lot of change when it comes to the next governor. Actually, I see a continuation of kind of where we're at, the work we've done together, the way we approach things, the way we think through representing many of, frankly, the community systems you all do, right? I mean, San Diego is a great example of where all three of us are well represented or represent you all in the audience. So in that way, I see it as an opportunity to build a healthcare agenda for the next governor. Maybe look at, what we'd like to see is, again, not look at OCA. I think all of us have had a conversation around the office of healthcare affordability that we could move that ship in a different way. And then I think it's going to be, I'm a little worried about where we will be left over when it comes to the Republicans in Congress and where we are headed by having fewer Republicans represent California, kind of what the next 3 years look like. Clearly, obviously California's made it clear that having more Democrats at the table is going to be important, as well as managing the votes in the House, but it also means we may have fewer voices at the table. So we're going to have to address that as a field together as well.
Thank you, Dustin.
Yeah, on Prop 50 specifically, Kat brings up a good point that having a diminished Republican delegation from California can be very problematic if government remains unified. If Prop 50 is the thing that flips the House and creates some separation there from unified rule, then it's probably worth that trade-off. I'm not talking about partisan politics. I'm just talking about from a healthcare advocacy point of view. Yeah. You can think of it in kind of those terms. If we get out of the midterms and it's still unified Republican control in DC, we're going to have 4, maybe 5 Republicans that can talk to the administration or talk to congressional leadership. That's not a great place to be. And I don't even know if those 4 or 5 would be the ones that we would pick if we were picking 4 or 5 of the current.
Right. Think of 3, I might not pick
San Diego, but right now, but that's just something to think about in that context. In the governor's race, we're in a difficult spot right now. All of you are watching it, at least to some degree, and seeing people come in, people come out. I've never seen the level of fluidity that we've seen in a congressional race with absolute no front runner at all. I mean, when the person with 15% is running around saying I'm the front runner. That's pretty shocking. And saying I'm the front runner when there's actually somebody at 16 or 17, but everybody knows the person at 16, 17 can't win. And I'll be very honest, I was absolutely head of the parade on the draft Padilla, Alex Padilla train. In part, he could have consolidated the field, and I think this thing would have been over in a couple of weeks. But I also understand why he decided not to. And actually, the reason he decided not to was the thing that would have made him, in my estimation, a very good and excellent governor in this moment in time. Right now, it is, and we're going to be spending a lot of time on this in our weekend in Santa Barbara. It is going to be difficult to navigate the waters about, who should, and I hope we can remain unified. The hope is that we keep the Prop 35 coalition together and we all move as one, and healthcare speaks with a singular voice. But it is going to be difficult navigating those waters. That being said, anytime there's a transition of governor, there are opportunities. There are risks and there are rewards to getting into a governor's race, but there's also opportunities in transitions to think about how the team is built, how it's constructed, how healthcare informs the debate, how we paint the portrait when people are running right now about what HR 1 means, not just as a talking point, just not as a point of inflection to be mad at Donald Trump, but what it means in real world delivery care. We have an opportunity to inform that in the debate. And I'm doing my best to talk to every single person that's running, even the people that are at 3%, because even the people at 3% are going to be at a debate stage talking about healthcare delivery. And if we can have them all starting to, say the same things, that's the moment where you can start to really get people focused on what their first 6 or 7 months look like when they come into office in January.
Well, definitely lots to think about. Sounds like the crystal ball on the governor's race still kind of murky. Francisco?
I think what I would add to that, to kind of give the room an opportunity to look behind the curtain of the work that we do, where there's real promise and opportunity, is that by working together, it doesn't mean we're always going to be on the same page, but particularly in 35, we stuck together through tough decisions when there were attempts to split us. And we stuck it out. And we all took heat for it as associations at certain times to stick together, both to get to the ballot and then in implementation. I think we've been moving through it. It's not easy, but we're able to pick up the phone, talk to each other. I heard this, what have you heard? And I see real promise in that for the next governor, right? Regardless of where we land, making sure that healthcare is a priority, that the provider perspective is a priority. It is shocking how many times decisions are made without a real understanding of how care is delivered on the ground. And it takes all of us together to paint that picture. It can't just be, one section of healthcare. And I think on the national scale, one of the things that I've seen, at least from my vantage point, as we've been moving both to try to prevent HR 1 from happening and now implementation, is accessing our national associations with each other. California is still significant. I know it doesn't feel like that sometimes now, but it's still significant on the national scale just because of who we are. And working with our other colleagues in other states, I know we do that. Like health centers are beloved in red states because they're in rural communities. So maybe sometimes we can advocate on our own because we're in California, but we rely on them to do the same. So I see real promise in that for the hospitals, the clinics, the physicians, Planned Parenthood, and others are part of our coalition.
So for the next question, Francisco, I'll start with you. And we've talked about a number of things, sort of the headwind side, whether it's HR 1. I know, obviously, the earlier panel this morning even touched on some of the budget challenges that haven't hit yet, but are on the horizon. And so between hospitals, physicians, and community clinics, who are all represented here, where do you see the clearest opportunity for us to align and advocate over the next 12 months with everything that's coming? Prop
35 implementation is key. The there's hope on the horizon, at least in the next 2 years, right, Dustin?
Correct.
So I think we can continue to move forward in that direction. The ballot initiatives in that space, both the three that we mentioned, and the opportunity for revenue that Dustin mentioned. I think that's long-term impact for us to continue to work together. So I think those would be the ones. The other one I'd be remiss if I didn't mention is Perora, and that's for those that might not have heard about that, but they try to redefine what's considered a public benefit, and there's litigation holding it up. If what's considered a public benefit is limited, that means a lot more people aren't going to qualify for public programs, Medicaid and on. And I think that's one of those other things that will add to that cascade of more patients that don't have coverage or resources. And I think that's something that we can come together. We saw it in Santa Barbara. You might have read about it a couple of months ago, where the county thought it couldn't provide care to certain patients. And that just showed how fragile we are, right? The way we're woven together. So I think that's another one that's potentially a thing, if we stick together and push back on, that we can prevent from happening.
Kat?
Yeah, I think I was going to say the same, that, that undocumented population, coverage issues there, I think are critical for us to partner on. And we're all part of coalition conversations around how to address those coverage issues. And I agree with you. It's not just the Medi-Cal coverage, but also when you think of the other social benefits that folks receive, we would be concerned about, whether it's food insecurity, et cetera. The other place is the Office of Healthcare Affordability. I think as we head into the year where we're going to look at enforceable standards, hitting that target, et cetera, I think there's places where we've already had conversations around how we can tackle that with the next governor, kind of coming together on some key points. We'll see how the lawsuit goes. Just to remind folks, CHA sued on the grounds that the lead up to that 3.5% target was not appropriately processed and considerate of access concerns. A win, quote unquote win, would be a reexamination of that. It's not an elimination of the target. So we will be living under a target. And I think we as healthcare providers can come together and really redefine what that looks like and how we would do that to address access concerns with the new governor, new administration.
Yeah. Next 12 months are not going to be fun. Not going to be fun. We've got cross-current things happening at the same time, right? We have our governor, who may want another job, who may view everything through the prism of that, and through the prism of the best way to get there and get through a Democratic primary is to spar with the administration federally. And that person finds a great foil in our guy here in California, and all of us are stuck somewhere in between those two things at a time when we really do need to drill deep on things like, how do we deal with coverage for undocs? How do we deal with provider tax uncertainty? How do we get ready for a 2027 MCO renewal, Program 9, Program 10? What are we doing with that? Francisco brought up a great point that 7,500 patients were almost immediately displaced in Santa Barbara and could happen again soon. Part of my intrigue about Alex Padilla was, again, that interest in those prickly problems. And when we have a budget deficit, there's easy places to go. One of the easiest places to go in a budget deficit is to cut everybody in this room, to cut providers. Not to reduce benefits, not to reduce eligibility, cut providers, can't cut education. If you're trying to bridge yourself over a year and come out looking good, you look for those kinds of off-ramps. And I think it's incumbent on all of us to continue to push our administration, the Newsom administration, and the legislature that in this moment we actually need to think beyond 12 months. We need to think about the implications for 2027, for 2028. I've been pushing my chief lobbyist, Kat's counterpart, that I want him to have every conversation in the context of when he's running for president, you're still here governing the legislature. So when the January budget comes out, I hope the legislature takes a longer vantage point than just 12 months. Because I think if we're stuck in a 12-month frame, it's not going to be good for anybody in this room. It's not going to be good for the patients that we serve. And I think one of the lessons learned of Prop 35 is that when we do stand together and we do fight together, that we can overcome pretty significant headwinds and pretty significant odds, even when we're being told to stand down. So I think we should be bold in the moment, as opposed to just hoping for the best or hoping for this or hoping for that, that whatever damage is done in the next 12 months is going to be more difficult, more in the way that our state budgeting works, in the way that when we hit deficits, the maintenance of effort stuff that has to go back into Prop 98 and Prop Education creates very significant future financial difficulties for us to restore things if we don't keep them held harmless in this budget. So don't want to lie to you, buckle up. For the 12 months. I don't know if based on the previous speaker, we're using an eraser or adding, or, but it's probably a bit of both. I'll use my own analogy. I think it's like we're trying to solve for a Rubik's Cube and half the stickers got taken off and we have to figure out what color that square is. But, you know, it can still be solvable.
You know,
but just buckle up on for the next 12 months.
well, and just to add to that, what comes to mind for me too is that we have a tendency to speak with the you know, what's impactful for us, right? We hear the numbers, like the billions of dollars, the patients impacted, and hearing the previous speaker just reminded to tell our stories, right? Reminding ourselves to tell the stories of how it impacts real people and what it means. I did hear a health center say it. They asked him, well, what does it mean? He said, look, we've seen this. We know how it looks. It means patient care rationing. Like something has to give. It means our doors are open, but at the end of the day, at least for a clinic, like you're going to close your door and the line, and that used to be the old model, right? There's people standing outside and you can only serve so many people and then people have to go home and come back the next day. For the hospitals, it may be, I remember diversion, right? The ambulance diversion, because the ERs were impacted. I think it's that not being, when I hear that, Dustin, I also hear like we got to tell our stories and not be shy about like it's going to hurt, it's going to be a rough year, and be willing to tell those stories of how it really impacts real people.
Yeah, I think those stories are important because it enables us up in Sacramento when we're doing our jobs to link them back to the stories that you're all telling, and that being very honest about difficult choices you're going to have to make about care delivery, maybe site closures, reduction of services, the number of people that will be impacted by that, the type of people that will be impacted by that is important. I'll give you an example. Last night and today was talking about Prop 35 implementation with the Newsom administration, and being very candid that the clearest pathway for us to get this renewed in 2027 with we're going to have to make changes to it, no doubt. But our best way to do that is to demonstrate to CMS that you're actually implementing Prop 35 because CMS likes Prop 35 because it gets them out of their presumption about what the dollars have been used for out here in the state of California, which in their imagination is everything that they hate. And so if we can do that, it will go better in the out years. But this is my tack back to the next 12 months, is short-term versus long-term considerations. And what I would try to make clear was if we aren't able to renew it in 2027 because we don't implement 35, we don't get those dollars straight to providers, you have a cascading effect of loss of provider tax revenue, but then that is going to result in significant budgetary losses for the state of California, which results and necessitates them cutting provider rates even deeper, which then triggers an access crisis for Medicaid patients, which will then result at some point of CMS coming back in and forcing the state of California to increase provider rates, but then that's a straight hit to the general fund, and that could be devastating for the state. So, we got to take a little longer term view. But if you all can do the storytelling that Francisco talked about, it helps us make those more technical arguments about why things need to be done, and have it not dismissed as, oh, you guys just want your money. Yeah, but there's a purpose to that want, and there's a reason for the want.
And I've worked with a lot of the folks in this room in the storytelling because you all have a fresh class of legislators, frankly. You have, I call them sort of the 10, 12 years, right? So with rare exception, most of them are going to be with us for the next 10 years. So now's the time to lay track. Now's the time to get them to understand the access concerns in your backyard, the access opportunities as well, and how those opportunities will change. I'm thinking of a hospital that's, expanding a service in behavioral health right now. Those types of things are exciting for a legislator to see, be a part of, understand, a supervisor, a congressional member. Those are the kinds of things that come off the block when you have to start addressing 4 and 5% decreases in revenue. So now's the time to get them invested in your strategies and help understand the real patient effect in that downstream consequence.
So with that, just looking at the time, want to open it up if there are questions. Obviously, have another one, but want to make sure that folks have a chance with any questions. So are there any questions folks have?
Hi there. My name is Sarah Pecoraro. I'm with Marsh McLennan Agency. We're a consulting firm. And so this conversation I love because we're on the other side of the table, right? Delivering renewals to employers on major increases on insurance. And much of the story that's told is that providers are receiving increases to themselves, right? Costs are going up. Insurance companies are essentially negotiating rates with the hospitals, with providers, and consequently that increases the rate for the consumer as well. So hearing your side is, of course, very enlightening. And my question to you is really, how are you experiencing the insurance companies and those contracts? And has there been any increase on reimbursement on your side of the table?
Should we take that first?
An uncomfortable conversation sometimes, but I think
Francisco and I are the low
valuable
cost.
Yeah.
So thanks for hosting us, Dimitrios.
I think what we're seeing is the plans are looking at the Office of Healthcare Affordability as an opportunity to cap some of that, which is frustrating because while they're capping at 3, our costs, because our cost is labor costs, right? So, we're going to have a strike next week. We had a strike the week before, and they're not asking for 2 and 3% increases in labor costs. They're asking for 5 and 6% increases, which are not matching up to, and I'm seeing them go higher, right? So we're looking at 7 or 8% increases, and these are on a very, I don't have to tell anybody in this room, but a very highly paid field. Healthcare is not a low paid field. So I think what we're seeing is the plans coming in using the Office of Healthcare Affordability as an ability to keep that increase low and below where we also see increases in pharma, et cetera. So I can't say we're not seeing increases. It's our job to ensure that we are making sure the payment stays at pace with expenses, and it's just not. So we're seeing that imbalance, and it's frustrating for the field. And it's going to continue to add to that access problem as we're seeing going forward. So we're not seeing the kind of 13, 14, 15% rate increase, premium increases in our contracts. If a provider in this room got a 14% increase last year, they're not telling anybody because it's not happening.
Well,
I can't think of a single provider that got a rate increase over 10%.
Well, I think what I would add to that, look, it's top of mind for voters. It's top of mind for everyone. Affordability is important, so we have to be prepared to address that. I will say, and this is not an answer other than point out another dynamic that's going to make it worse. I'm an employer myself, right? I've seen a 10% increase combined in the last 2 years. And we provide full coverage for family and our employees, and it's hard. The fact that it's all connected together, right? The fact that less people are going to have coverage is going to make the pool less diverse, which means that it's going to get more expensive to provide coverage for the few people that are there. So like that's part of the domino, right? It's all interconnected. So the Medicaid funding is important. The Medicare piece is important because if you defund those two, then the commercial plans, it goes up too. So I think that's critical also in terms of how we look at the problem beyond just looking at the insurance companies.
And real affordability comes with primary care, specialty care, early access. Affordability doesn't happen in the ER. By the time you've hit the ER, we're hitting, and you all know this. So I think as we look to new paradigms and new shifts, I'm seeing some incredible models in how you all as providers are looking at affordability for the consumer. I was just talking to a member who is, rather than doing an urgent care, doing a walk-in clinic because the urgent care rate for the consumer is higher than a same-day appointment for a doctor, So seeing all of you look at what is affordable for the consumer, really digging in and tackling, and I know, Dustin, a lot of the medical groups focus on real affordability happens in that, prevention, primary care. I mean, the clinics are a critical part to how we manage keeping our patients out of the ER because hospitals are the most expensive place to get care because we're labor intensive and all the other things. So.
And I on that, and I think Kat did a good job of capturing that. Like, we should not let a crisis go to waste here. And on the affordability thing, on all the other pressures with increases in uncompensated care and the like, it is an opportunity for us to rethink how we do a lot of the business lines and how we advocate and what those, how we can think more cooperatively. I'm involved in a bunch of different projects across the state of rethinking the connectivity between community physicians and larger institutions, usually hospitals, but sometimes FQHCs. Instead of having community physicians be jealous and bitter about the PPS rates that Francisco's members are paid, but thinking about how can we connect and maybe use the EHR backbone of the FQHC in that rural community to help support the community physicians who don't have that capacity or don't have the bonding capacity of a hospital system or the capital capacity of a finance system, but can provide a more affordable, cheaper point of care or something that's more connected out there. Maybe looking at hub and spoke models down here in San Diego, thinking about how to support Imperial County, where obviously there's been a lot of difficulty with the hospitals out there, but you still have a really strong base of community physicians, but they don't have the capacity that some of the systems here in San Diego have. How can we connect those and create even warm handoffs between the community-based physicians out there and the specialty core here, as opposed to trying to place specialists out there, but having the primary care physicians getting teleconsults with some of the systems here, all those kinds of different things. And we have the same consideration potentially up in Northern California, everything north of Sutter and UC Davis potentially being supported, because you can't replicate that up there in Paradise or up in Modoc. So I think there's opportunities to think creatively, and again, breaking down some of the barriers, not us banging on CHA over site of service, not banging on Francisco's members over PPS, but we end up all sharing members anyway, thinking about that. How do we leverage the strengths of each, the historical strengths of each, and the new structure? And it's been done in some places. I'm really curious, as I'm heading up to Santa Barbara, I keep talking to Sansum about their tie-up now with Sutter, and how's it going? And it seems so far to be going a whole lot better than when Sutter, way back in the day, did the tie-up with Palo Alto Medical Foundation. So there seemed to be a lot of learning that occurred there about, again, leveraging the strength of what Sansum had as a core non-facility-based entity, but now being able to tap into the strengths of Sutter up in Northern California. So again, really interested in tracking some of those things and thinking how we implement some of that to be able to do costs in a more efficient way. And by the way, I got hit with 17%. I've been held flat for 5 years as an employer, got hit with 17% this past year. That was fun for my budget.
We'll start with an A.
Yep.
So obviously affordability is a topic that is on everyone's mind. I do want to end on a up note. So I'm going to ask you each take 30 seconds or so. We've touched on a lot of things. Obviously uncertainty, challenges that are ahead, budgets, elections, policy. If you were to sort of just describe in 30 seconds, what gives you hope right now about the future of healthcare in California? Francisco, I'll start with you.
I think rooms like this. There's a secret sauce in San Diego, I think. I've worked. I used to be Dustin's general counsel. Worked with the doctors before. I worked for the apartment association at one point. And in both those sectors, and now working with the health centers, you do a really good job of coming together as a healthcare ecosystem when you have an existential or a big challenge that impacts you all. I know you're all competitive with each other at times, but when you have something that impacts you all, you in this outside of healthcare, you do that really well. What gives me hope is I think we're building that, or we have that now in Sacramento. And Prop 35 was part of that bringing us together, and we actually like each other.
Yeah.
So
wait, we do?
Yeah.
That's why you left.
And it's just three of us now, but there's others in healthcare. And we're able to come together and have disagreements and move forward. And most importantly, pick up the phone and say, I heard this, what do you think? As opposed to assuming. It's true at the local level, it's true at the state level, and I think it's true nationally. It only takes a couple people to come together and say, let's do this, and you can build the momentum. So that gives me hope that as we have these headwinds and we look to the future and to make healthcare a priority in the state, that gives me a lot of hope.
I would add to that 100%. I think having been in the job through COVID, through the $25 minimum wage, through all the things that we've had to face together, I think that strength is just the beauty of that base really to work from has been good. And I agree with you, San Diego does have a secret sauce. I'm going to add Sacramento in there too. Seems like those providers all kind of figure out how to work it out. I also honestly have been the last few months really impressed as I've gone in the field with how our folks are using technology, not in a way that screams AI and we're going to replace people, but really in a way that is additive to the patient experience, additive to the efficiency quotient that we all need to meet the affordability, and then done in a way that is ethically smart for the patient. It's been just that watching our folks from our smaller clinics. So I know we're using it in the patient experience, medical groups, and then the larger hospitals. So I do think there's some hope there in how we tackle that. And I say hope because I've also enjoyed watching all of you be very militant about the ethical use of technology. So,
what gives me hope? Well, there's much. First, Dimitri, thanks for having us down here and inviting us. I left rainy Sacramento to come down here and, again, really think about my life choices in that regard. But as Paul Hedgie, our local CEO who moved from Sacramento down here, reminds me all the time. But what gives me hope is what Francisco talked about. One, our ability to be able to come together, our ability hopefully to be creative, and also to realize and recognize that even though this moment feels really awful right now, this isn't like we're sitting around a room during the dot-com bubble and we all had like an app that we had created that yesterday was worth like $10 million, and then we're all sitting in a room and we looked at our phones and it wasn't. Healthcare is a necessity. It is a thing that we've seen time and time again, whether Democrats go after it, whether Republicans go after it, ultimately voters make them pay the price. We saw in Prop 35, we ran a pro-Medicaid campaign. I had to overrule the campaign consultants who wanted to run a cynical campaign about politicians spending money. We ran a pro-Medicaid campaign. It passed with 67.9% of the vote. 2/3 of Republicans, self-identified MAGA, supported Medicaid expansion and investment in the state of California. We saw very quickly what happened to approval ratings for Republicans in Washington, D.C. When they attacked Medicaid. We see the peril of the not addressing the Affordable Care Act. We see right now the looming peril of sharp increases in share of cost and share of premiums for employees. We have to remind ourselves that we provide something that people fundamentally view as a human right, as part of dignity, and they want it, and politicians mess with it at their own peril. And our creativity in part has to recognize that strength, that ability that we have. And I spent this past weekend back in DC at the AMA House of Delegates, reminding the AMA of what we did out here on Prop 35 and pushing them to stand up in a way that I feel very disappointed about that they didn't. But if I had seen AMA, AHA, your National Association, Francisco, the national entities of all the other provider groups get together like we did on Prop 35, I don't know that HR 1 comes out the way that we did. I think we got to get strong, we got to get bold, and remember what we're fighting for, and not just assume that these bad outcomes are going to come, because voters are actually with us, and they're with us in a really, really big way on a bipartisan basis.
And I would think that's a great point to end this discussion on. Collaboration and working together is going to be the key as we move forward. We know we're not going to get to a place where there are no clinics, hospitals, doctors, because healthcare is something that everyone needs. So obviously, it'll take all the minds in this room, all the folks up here to figure that out. So with that, we'll wrap up this panel. If we can give them a round of applause, please.